So I was talking about breast conserving surgery with impalpable cancer. It's an example on the picture. As you can see, there is a ultrasound guided wire localization being done, and the wire is shown there with the arrow sign there. As you can see, it has gone through the lesion, and on the right hand side you could see my cursor is showing there's the lesion shown on ultrasound scan. To locate this, this is one of the way to excise impalpable lesions with ultrasound wire localization. And these are the pictures of the wires. I initially got UK, but now it's all available in Bangladesh as one of the companies importing them. And a lot of my other colleagues in different hospitals are able to use this technique now in Bangladesh. Once the wire guided excision specimen is done, as you can see, this is one of the wire. There is another second wire because sometimes the lesion could be a bit difficult, and the sonologist might want to bracket the lesion so that two wires are placed on either side of the lesion and the whole lesion is excised along with the wire. So that's what it is shown there. And this is the sutures made on the specimen for orientation, because pathologists would like to know the orientation of the specimen so that they can confidently report the margins status, whether the cancers are positive in any of the margins. So you do need to have a three-dimensional orientation. The typical orientation suture technique is a long lateral suture, LL, short superior suture, SS, and double deep sutures, DD. So that is sufficient to give a three-dimensional orientation. So once you have excised an impalpable lesion with the help of ultrasound guidance or a wire, you would like to X-ray the specimen, which is a routine practice. But in order to understand radiologically which margin is clear from the lesion, at least radiologically, we put marker clips. As you can see, we use AIM. Stands for anterior, I stands for inferior, M is medial. And AIM is 1, 2, 3 clips, means anterior 1 clips, inferior 2 clips, medial 3 clips. By doing that, and you could use simple clips that are available, titanium clips are available in every hospital in Dhaka. So it shouldn't be a problem to orient with clips, titanium clips for radiological view to see whether it's completely excised or not. This is a slide where showing comparison of the X-ray procedures. This is the specimen, and being X-rayed. That's in Dhaka, because we haven't got in Dhaka. We haven't got this mobile monitor. As you can see, this is the specimen placed inside the cabinet, and the X-ray is taken where you could see a wire and this X-ray specimen. So we have got this mobile cabinet, but it cost about 35-40 lakhs taka. I'm sure it can be easily be bought in Bangladesh as well in future. Something to do list. This is an excised specimen. The lesion is spiculated lesion. The wire has gone through, and there's the surrounding margin. Radiologically looks like well excised. And the next picture my cursor is showing, you could see there is a marker clip that was left during core biopsy to diagnose the breast cancer. And core biopsy, that marker was left in situ. And subsequently, a wire is placed close to that marker clip to locate the lesion, and that was excised. So it's a wire-guided wide local excision under X-ray specimen. And that is the X-ray specimen of this lesion, the one I can show on my cursor, this picture. That's been excised specimen, and this is the X-ray specimen of the bracketed and the lesion. I could see some calcification and a lesion right at the center of the specimen, bracketed between two wires. So you could use ideally one wires, but sometimes you may want to use more than one to localize the lesion in its entirety. Now, this is one of the questions typically asked: where should we put incisions? Generally, skin crease incisions could be applied. Medially, and you should make transverse incision. Laterally, you could make curvilinear incisions. Circummalar incisions are quite a good technique, and try not to take more than 1/3 of the circumareola, as it increases the risk of circulation to the nipple. You could also do
স্যার ইনসিশন গুলা কিসের উপর ডিপেন্ড করবে?
It depends on where
যে
the
কখন
lesion
কোন
is.
ইনসিশন দেব?
Suppose a lesion
Okay.
is at the 6 o'clock position. You could do a radial incision. As you can see, I'm moving my cursor. If the lesion is close to
Yes.
the areola, you could make a periareolar or circumareolar incision. Or if the lesion is at the upper outer quadrant, you could make a curvilinear incision at the upper outer quadrant. If it is in the medial, I would suggest try not to put a curvilinear incision, make it straight. As you can see, I'm moving my cursor sideways. Can you see that?
জি স্যার, জি স্যার।
So medially try to make transverse incision, but laterally you could make transverse incision or curvilinear incision, or you see I'm moving my cursor along the crease of the breast.
জি স্যার।
It gives a lazy edge incision. By doing that incision, you could approach axilla, and then you could approach cancer with a single incision. So there are various options. Another incision is typically used is inframammary crease incision. Patient stands up or sitting position, you lift the breast up a little bit, and you could find the inframammary crease, so you draw a line. So that's another way you could approach breast tissues if the lesion is at the 6 o'clock position or somewhere in the lower aspects of the breast. And you are in the lower half of the breast, you could easily use an inframammary crease incision and you could excise the lesion. To be honest, through an inframammary crease incision, you could approach prepectorally behind the glands anywhere in the breast, and then you can go up to have this lesion removed. So this is one of the commonly used incision, inframammary crease incision, to do breast surgery, be it a benign or malignant lesion. Now, this slide is quite important because surgical technique is a challenge for breast cancer surgery, and few basic principles we need to understand. One is incision site and size. Try not to make a huge incision, but reasonable size is in like 7 to 8 centimeters should be enough, but you could make it bigger. And I have on my previous slide shown where the site of incision should be. There you go. As you can see, I have already elaborated different incision sites.
আমার একটা কোশ্চেন ছিল স্যার, এরকম কি আছে
বলো।
যে ইনসিশনটা আমরা যেটা জানি যে রেডিওথেরাপি দিতে হয় উইথ স্কারকে কভার করে, এই জন্য স্কারটা ক্যান্সার লাইন বরাবর না হলে রেডিওথেরাপিস্ট রেডিওথেরাপি দিতে পারবে না, সো আমার স্কিনের ইনসিশনটা হতে হবে ক্যান্সারের উপরে, এরকম একটা আমাদের একাডেমিক্যালি শেখানো হয়। আপনি এটা কি মনে করেন?
This is a false perception and wrong and entirely inaccurate advice. The reason is, in oncoplastic breast surgery, incision could be somewhere and the lesion could be somewhere entirely somewhere else. So I mean, maybe 40 years back, that was a standard practice, but with the advent of oncoplastic breast surgical technique, incision is somewhere. Say, for example, you make an mammary crease incision and you take a subareolar lesion out. You could easily do that. And then the radio-oncologist, do you think should be giving radiotherapy, boost radiotherapy to inframammary crease region? Definitely not. So the best way to localize, if a radio-oncologist wants to give a boost radiotherapy, a surgeon should put titanium clips at the base of the tumor site with at least on the four corners, 4 titanium clips. That gives a easy identification for radiologist, radio-oncologist. to know exactly where to give this post radiotherapy. So don't get confused with the scar, because the scar could be somewhere else from the actual lesion or cancer. Is it clear? বুঝতে পেরেছো?
জি স্যার, থ্যাংক ইউ।
Okay, so I'll carry on with principles of surgical techniques here. So the excision should be from skin to pectoralis. I repeat, when you excise a cancer surgery, you should excise from subcutaneous plane all the way down to the chest wall. For example, if you see this picture, there is incision given around the areola, perioral incision, and lots of undermining done. So undermining of the surrounding tissue subcutaneous plane, don't go too close to skin. You need to free the subcutaneous plane all around it. And as you can see, the arrows reflects that area of dissection. And then you excise from skin down to chest wall. Can you see I'm moving my cursor? So that is one of the principle of breast cancer surgery, skin to chest wall muscle. And obviously, if that is the cancer, you want to take surrounding normal tissue, as I'm moving my cursor, just showing the area of extent of excision. And as you could see, there is a dissection of subcutaneous plane, the tissues all round. And then if you see the arrow goes downwards in front of the major muscle, behind the gland. So you create a plane behind the breast tissue in front of the pec major, free this up. And you have also freed the breast tissues from the subcutaneous plane all around it. That gives the whole chunk there and on this side freely mobile. And you could bring these two together. So once you've done a wide local excision, once you have dissected through the subcutaneous plane as well as prepectoral plane, surrounding parenchyma can be easily be apposed together with sutures. So this is one of the key way to give a better cosmetic outcome, like a level 1 oncoplastic surgical technique. And as you can see, even if someone has got a small breast tissues, you'll always find breast tissue behind the nipple. So if you could do a nipple areolar complex undermining, you should be able to find enough breast tissue, breast parenchyma to mobilize in different direction towards the wide local excision site to fill the gap and to reshape the breast tissue. So excision
Sir,
from skin to pectoralis, bolo?
স্যার লেভেল 1 লেভেল 2 এটা বলতে কি বুঝে? মানে
Level 1
level 2
oncoplastic surgery are basic oncoplastic technique that what I am describing now, where you would be taking less than 20% of the breast tissues, of the whole breast tissues. You would not have to remove any skin and to shape it extensively. There is a level 2 oncoplastic surgery. Level 1s are like simple movement of tissues, parenchymas, and the 3 steps that I'm mentioning. You excise from skin to pectoral muscle. You could undermine the skin, and you could undermine the nipple areolar complex, and then you could recentralize the nipple areolar complex. These are all basic oncoplastic technique, could be learned by anybody, and you could like C1 do one style basically. So you do not need a lot of training to practice this. But for level 2 oncoplastic surgery, are a bit more complex surgery, and where you need to take more than 20% of breast tissues removed, associated with the skin excision as well. And then you shape the breast up. So these are called level 2. Am I clear?
Okay. জি স্যার।
So just to remember the basic level 1 oncoplastic surgery during when you do a breast conserving surgery, you should remember few things, at least 4 things. One is skin to pectoral muscle excision, extensive skin undermining. But when you do skin undermining at the subcutaneous plane, please keep some subcutaneous tissues. If you are very close to skin, when they heal, it heals with some funny shape. The skin doesn't like it, and it may compromise its blood circulation as well and healing. The third point to remember is nipple areolar complex undermining, which we often practice on level 1 oncoplastic surgery, followed by nipple areolar complex recentralization. So always remember these 4 steps. Now, as with any breast conserving surgery for any invasive cancer, you would want to stage the axilla as well. And if an axilla is clinically ultrasonically normal or negative, when you excise the breast with a wide local excision, you would also want to stage axilla in the form of a sentinel node biopsy. In olden days, you used to do axillary clearance for any invasive breast cancer, in fact, for any cancer, and that was an extremely over treatment because 80-90% time the nodes are normal, and you manage to develop this patient's arm to a lymphadematous arm, and patient will live rest of her life with a hugely swollen arm. Definitely, it's a crime, and it could be a medical legal issue nowadays if a surgeon does unnecessary axillary clearance without offering a sentinel node biopsy, which is a basic gold standard technique nowadays. So, as I was mentioning earlier in my lecture, that de-escalation is key. Same thing goes true for axillary staging. Instead of doing unnecessary axillary clearance, you should consider doing sentinel node biopsy. If a person has got positive lymph node during ultrasound images and FNAC shows cancer cells, and patient has got a positive lymph node in axilla, then there is no need to do a sentinel biopsy. You should be going ahead with old style technique of axillary clearance. When I talk about axillary clearance, I often hear about this term of axillary dissection. Basically, axillary dissection and clearance are kind of same thing. But when you talk about dissection, often it is perceived that within the fat, they just search for a few lymph nodes. Once they take in 10 or 20 nodes, and that's it. But when you do an axillary clearance, there are level 1, level 2, level 3, where you would remove the fatty tissues containing lymph nodes. And if the fatty tissues are removed, which are present below the level of pectoralis minor along axillary vein, that fatty tissue will have the lymph nodes. These are the level 1 lymph nodes. And the lymph nodes within the fat that are present alongside axillary vein at the lower apex, which is behind the pectoral minor muscle, are level 2 nodes. And if you want to do a level 3 clearance, you have to divide pec minor that is attached to coracoid process. You need to go higher up, which would be almost an obsolete process nowadays. Olden days, they only used to love doing axillary clearance level 3, but the guidelines suggest if you have to do axillary clearance, try not to do more than level 2 unless somebody has got seriously large nodes all the way higher up, which is a rare scenario. And in fact, this sort of patient should be initially be offered neoadjuvant chemotherapy to downstage. And by downstaging, you should be able to do level 2 axillary clearance, and often you find there are good response. Now, coming back to sentinel node biopsy, which is the gold standard, ideally you should be using blue dye or any dye with a second tracker with isotope, technetium 99 if available. We in UK, we've been using it for almost 17, 18 years. But unfortunately, Bangladesh, we are yet to have that isotopes available. We have got the gamma probe and SMB machine, but hopefully in next few months' time, once we are able to get hold of those isotopes to be able to inject in the breast, then we should be able to do the gold standard technique of a dual tracker technique with dye and isotope together to do a sentinel node biopsy of axilla. Now, coming to this slide, you could see Nafis is injecting the dye at the deeper aspects of the breast. Olden days, they used to inject this dye intradermally or subdermally, but please don't do it because it gives a really bad colored skin, and that can be present there for a long, long time, maybe particularly that area. So try to inject it as deep as possible on the lung tube, on the breast parenchyma, and give a good massage for 5 minutes in a circular fashion, like this way. And it really does, this dye really travel to the lymph nodes in the axilla right here. And as you can
আমার
see,
কিছু কোশ্চেন ছিল স্যার, দু একটা হচ্ছে যে
বলে ফেলো।
সাপোজ আমরা হলো একটা আনপ্ল্যান্ড লাম্পেক্টমি করে ফেলছি, আমাদের টিউমারটা আউট হয়ে গেছে, এখন আমরা জানলাম যে ক্যান্সার, এই রোগীটার এসএনবি করা যাবে কি যাবে না?
অ্যান্সার, সোজা সাপটা অ্যান্সার হচ্ছে অবশ্যই যাবে।
টিউমার কিন্তু আউট স্যার।
তুমি যদি মাস্টেক্টমি করে ফেলো তাহলে যাবে না। আর তার চেয়েও বড় জিনিস হচ্ছে, কেন একজন সার্জন আনপ্ল্যান্ড লাম্পেক্টমি করবে এবং সেটা পরে ক্যান্সার হবে? ইটস এ নো। ইট কুড বি এ ইজি এ মেডিকো লিগাল কেস। সো এখনকার দিনে তো ইন্টারনেটের বদৌলতে এটা আমি জানি হরহামেশা হচ্ছে, কিন্তু এখন সময় আসছে এই রং প্র্যাকটিস গুলোকে বন্ধ করার। তুমি যদি এখন ঠেলা গাড়ি করে তোমার বাসা থেকে আমাদের হাসপাতালে জয়েন করতে যাও, তাহলে কিন্তু আমার মনে হয় না ইট উড বি এ ভেরি গুড আইডিয়া। তুমি নিশ্চয়ই একটা গাড়িতে চলে আসবে। তো মেবি আজ থেকে ৬০-৭০ বছর আগে ঠেলা গাড়িটা খুব অ্যাপ্রোপ্রিয়েট ছিল, কিন্তু এখন যদি তুমি ঠেলা গাড়ি করে ঢাকা শহরে চলতে যাও, তাহলে লোকজন হাসবে এবং রাস্তাঘাট ব্লক করার অপরাধে তোমাকে লোকজন অ্যারেস্ট করে ফেলতে পারে। কারণ একটা বিজি রোড যেখানে স্পিডি কারগুলো যাচ্ছে, তুমি যদি একটা ঠেলা গাড়ি নিয়ে মাঝখানে চলতে থাকো, বোঝো অবস্থাটা। আমি একটা অ্যালগরিক্যাল একটা কম্পারিশন দিলাম এই কারণেই যে এককালে হয়তো ওটা অ্যাপ্রোপ্রিয়েট ছিল, কিন্তু এখন আর সেগুলো অচল হয়ে গেছে। সেম থিং, অ্যাক্সিলারি ক্লিয়ারেন্স এককালে যে কোনো ক্যান্সারের জন্য, ইভেন অ্যাক্সিলাটা নরমাল, তারপরও সবাই করতো, কিন্তু এখন এগুলি করলে স্পেশালি উন্নত বিশ্বে তো প্রিজনে যাওয়ার সম্ভাবনা অলমোস্ট শতভাগ। আর বাংলাদেশের মানুষও অনেক বুদ্ধিমান হয়ে যাচ্ছে, অ্যান্ড দে নো ওয়ার্ল্ডও তাদের হাতের মুঠায় চলে আসছে। সুতরাং we all should be careful doing oldie style harmful surgical techniques. Coming back to the point of sentinel biopsy, as you can see, Nafisa has managed to remove a blue colored node, the sentinel node. And this is my cursor. I'm showing there's a blue sentinel node, and there is another node which is partially blue. And before the node was removed, that's the node. That is how it looks like. Once you make incision in axilla, the incision is marked. As you can see, my cursor is showing the first picture on the slide. There's the mark is given first with a marker pen with an axillary skin crease, and then you do an incision, go through the deeper tissues, and then approach axilla, as you can see on the far other side. And there's the node. There's the node is being visible, and now it is out. That gets sent to, in UK, we send it to lab for OSNA study, which is one-step nucleic acid amplification, where you count CK19 mRNA copies in the lymph node tissues. Normally, these proteins, the CK19 mRNAs, are present in breast duct epithelium. Now, when there is a breast cancer, that means those duct epithelium becomes uncontrolled growth, and those cancerous breast tissues, when they travel through the lymphatic channels into the lymph node, they carry their CK19 mRNA into the lymph node. Normally, they are absent in the lymph nodes. So that's where the concept of OSNA study comes along. If OSNA study of the lymph node, where they will lysate the whole lymph node, lymphatic tissues, and then machine will try to count the copies of CK19 mRNA. If they are more than 5,000, they are called macroscopic positive, like positive and macrometastasis. Or if it is less than 200, then 200 or 250, you call it micrometastasis. And if they're absent, then it's normal negative. Now, we have gradually shifted to perform axillary clearance. We used to do axillary clearance if the SNB was positive. We done it for about 7-8 years, and then we done our research, and we found out subsequent axillary clearance, SNB positive axilla, only few percentage had further positive nodes. And that's when the guidelines got changed. And by that time, Z11 came out, and recently, a few years back, Amorous trial also came out. So based on Z11 outcome data, which changed the practice of axillary management significantly in USA first, following that to Europe and including UK. So what happens now is, if a sentinel node biopsy is positive, you do not have to do axillary clearance unless there are exceptions. Unless you're doing a sentinel node biopsy for a new adjuvant chemotherapy patient who has completed her treatment and then having surgery. In that case, if that patient's axillary SNB is positive, you will have to do axillary clearance.
আমার একটা কোশ্চেন,
There are other exceptions, এক minute, Nafisa. The other exception is if you done a 3 sentinel node biopsy and all 3 sentinel node biopsy came out as positive, then you have 2 choices. Either you do an axillary clearance, ideally, or you do radiotherapy to axilla. So coming to the point is, if SNB is positive, you do not have to do axillary clearance based on the trial outcome. Z11, Amaros, and there is another trial, and in fact quite a few trials have come along saying exactly the same thing, that you can safely avoid axillary clearance instead of offering axillary radiotherapy to radiotherapy and to breast as well. Yes, Nafisa, bolo ki jante chao?
তার মানে আমরা বুঝতে পারলাম যে স্যার এসএনবি যদি পজিটিভও হয় তাহলে আমাদের অ্যাক্সিলারি ক্লিয়ারেন্সের দরকার নেই, আমরা রেডিওথেরাপি দিব, যেমন আমরা ব্রেস্ট কনজার্ভিং সার্জারি করে রেডিওথেরাপি দিচ্ছি, আউটকামটা সেম এরকমই। স্যার আমার একটা কোশ্চেন যে আমরা
correct. Guidelines বলে যে you have to treat axilla if SNB is positive. Either you do it with radiotherapy or axillary clearance. আর Amaros trial clearly বলে দিয়েছে যে axillary clearance করলে 29% lymphedema এবং other complication হয়, high percentage, whereas radiotherapy দিলে 50% less chance of lymphedema. তুমি নিশ্চয়ই যেটা কমপ্লিকেশন বেশি হয় সে অপারেশন করতে চাবে না। You want to make people's life better, not their lives further complex, right?
স্যার স্যার আমার কোশ্চেন এরকম যে আমি যদি অ্যাক্সিলারি ক্লিয়ারেন্স করি, আমি ক্লিয়ারেন্স করে হয়তো বা 15টা লিম্ফ নোড পেলাম বা 12টা, আরেকজন পেল 15টা, একজন পেল 25টা, কার অ্যাক্সিলারি ক্লিয়ারেন্সটা গুড হয়েছে বলে আপনি?
একটা জেনারেল পারসেপশন আছে যে যে যত বেশি লিম্ফ নোড বের করে ফেললো সে একটা বিরাট সার্জন হয়ে গেল, কিন্তু এইটা বুঝলো না যে সার্জারি ইজ নট স্প্রিন্ট, যে আমি খুব ফাস্ট অপারেশন করে ফেললাম অথবা আমি 40টা লিম্ফ নোড বের করে ফেলছি, আমি একজন বিরাট সার্জন। এগুলো ওল্ড স্টাইল কথাবার্তা, and those days are long gone. You need to make sure that you're not causing any harm to patient, number one. If you can't do any benefit, at least don't cause any harm. So minimal, you need to have 10 lymph nodes. There should be 10 lymph nodes within the axillary fat that you remove. You cannot just cherry pick lymph nodes. একটা করে হাতে খুঁজা 10টা নোড বাইর করে অপারেশন করে ফেলা তা না। There are certain steps to do axillary clearance, and that would be another day lecture where I would like to go stepwise surgical techniques to do a proper axillary clearance. Ideally, we do not do level 3 axillary clearance, which is kind of almost obsolete. We do mostly level 2 and few cases level 1, but most of the time we do level 2 axillary clearance. So does it answer your question?
Yes, sir. So আমরা next slide যাই স্যার।
Okay. Now, breast conserving surgery is one of the facets, like a patient could present with a lump or an impalpable lump found on mammo or ultrasound and biopsy triple assessment eventually confirming as a cancer, or a patient could have a large cancer, say 8 centimeter in a breast, axilla normal, or maybe 1-2 positive nodes. And there are certain criteria to decide neoadjuvant chemo, and this is one of the criteria that you could give neoadjuvant chemo, means chemotherapy given prior surgery. It could downstage, and 70% time it would have some downstaging, and up to 20, 25, 30% time you would find a complete response, means the tumor can melt to nothing, which is why it creates a problem in history of Bangladesh breast cancer surgery. until recently, any patient who were offered neoadjuvant chemo, even after the complete clinical response, they would end up with a mastectomy. And that is like a current teaching elderly generation of surgeons. But the modern surgery has moved away from this concept. And instead of removing the whole breast, even after a good response, we could simply do a wide local excision, and that can be done simply with putting a marker clip. And this picture shows a hydromark gel is inserted with ultrasound guidance, and that's the pictures. And this is why the insertion is being done to locate and to insert that hydromarker into the center, at the center of the lump. Can you excuse me for 30 seconds, please? Can you hear me now?
Ji, sir.
Hello?
Yes, sir.
Okay, sorry, my laptop suddenly was dying.
Yes, sir. We
A
can hear
typical
you.
problem.
Yes.
Now, this is an innovative technique we have introduced in Bangladesh. No one has ever done this before. As you know, Bangladesh, there are certain people who has got a tendency to steal someone else's credit. And we try not to value the innovation and technology transfer that helps patients significantly. And this is why I wanted to make sure so that the audience understands that these things are never available, never used in Bangladesh. We got this technology transfer from UK to Bangladesh, and we taught surgeons. Nafisa came to UK 4 times. She was the one that did insert the first marker clip, the hydromark clip, into a cancer before chemotherapy was started, and subsequently that was done almost 2 years back. And that was subsequently patient had a good response, had a wire-guided wide local excision and axillary surgery, and she has had all the treatment with radiotherapy. Currently, she is on hormone therapy, and she's doing great. And we have done about 7 or 9. How many cases we have done, Avisa?
Still now I have done 7 cases.
7 cases. So
First patient was your patient from abroad came to you.
From Saudi Arabia, yeah, that's correct. So she's doing great, alhamdulillah. So what I'm trying to say that these are the newer concepts. I mean, it's quite an old concept in modern developed countries. In UK, I've been using it for almost 18, 20 years. But for Bangladesh, this is absolutely fresh, new idea being introduced. And I'm pleased to say that following us, a few surgeons and few institutes that have already beginning to follow this practice, which is eventually going to benefit patients. So that's where our practice change should aim. Why we change our practice? Why do we develop ourselves? So at the end of the day, it benefits our patients, our public. So this is where the benefit of technology transfer is important. Now, as you can see, this is the picture. This is Humara Appa. She is, to me, she is the best sonologist in Bangladesh. And she also came here in my unit for training. And she has had some hands-on training as well. And we are trying to insert a hydromark into the cancer. And this is how it looks like post-insertion. That is the cancer. And a hydromark gel is inserted right near to the center of the cancer. So once that large cancer gets shrunk with chemotherapy, a sonologist could follow that that hydromark under local anesthetics, insert a wire, and perform a simple wire-guided vital excision, and therefore you can avoid unnecessary mastectomy. As you know, the mastectomy can give a significant negative impact on patients' physical as well as psychological aspect, and it has got personal, social, and other stigmas attached to it, and there is no point doing an unnecessary overtreatment that can be simply be managed with a breast conserving surgery. Am I clear?
জি স্যার, আমাদের দেশে তো স্যার ক্যান্সার প্লাস
Now,
বেশ বড় হয়ে আসে এবং আমাদের দেশে এটার ইউজ অনেক বেশি অ্যাকচুয়ালি হওয়ার কথা বা আমাদেরকে অনেক হেল্প করার কথা থাকার জন্য।
I'm very hopeful that following introduction of this technology in Bangladesh, lot of newer surgeons, because I'm hopeful about the newer surgeons who can easily embrace the new techniques to practice it for the patient's benefit. So because Bangladesh have got no national breast screening program, which we are fighting for the last few years, hopefully eventually we will win. Because there is no mammographic screening facilities available nationally, just some private units and some local hospitals, few places here and there doing it, but there is no like a national protocol. Because of this and because of lack of awareness, patients are still presenting fairly advanced stage in Bangladesh. But things are changing. In last 5 years, 5 to 10 years, people are more aware. They're more body conscious. They are coming to see us. If there is a breast lump, they will seek advice from doctors. I would suggest that those patients should not see anybody who hasn't got expertise in breast surgery or modern knowledge of breast surgery. If you got a joint problem or if you have a fracture, you would see an orthopedic surgeon. You don't come to a cardiac surgeon, would you? Same thing goes true. A breast disease should be seen by a breast surgeon or a general surgeon with a special interest in breast disease, not by a gynecologist, not by an orthopedic surgeon, not by a brain surgeon. So to get the best treatment, you have to find the right person with the right specialist interest. And these are all modern concepts, because in olden days, one surgeon could do whole body, like what you call it, like a whole body surgeon. He could do everything, anything and everything. But that concept has gone, is died. It doesn't exist anymore. Hello?
Hello?
Sorry.
Hello?
So coming back to the slide, we are talking about marker clip insertion for neoadjuvant chemotherapy. I think I've given enough information for you to understand. Now, coming to breast conservation.